Thank you, Ben.
We appreciate the opportunity to present this morning. I'm going to speak about disease-based mortality and using an enterprise data warehouse to answer clinical questions. This is a work done by the Vanderbilt Surgical Health Services Research Group. These are my disclosures. Percutaneous endoscopic gastrostomy, of course, originally developed by Drs. Ponsky and Gowder in the early 80s, remains the first natural orifice transluminal endoscopic surgical procedure that has gained and sustained to have clinical traction in practice today. Arguably, it has changed the indications for gastrostomy as both surgeons and gastroenterologists adopted the technique. However, the reported mortality is quite high and varies from 16 to 43% in the literature. And we aim to look at this a little bit further, and basically the aim of this study was to evaluate disease-based short and long-term mortality in patients undergoing PEG. And one of the main reasons why we wanted to do this was basically to identify a little bit more precisely the populations that we should take a lot of caution in doing PEGs in, and also conversely looking at those who may benefit from the procedure. This was an observational cohort study. The data source was the Vanderbilt Procedural Outcomes database. This is a database based on the enterprise data warehouse concept, and I'll take a little bit to talk about this. This is basically a system where you can obtain clinically rich information, unlike administrative data where you're limited on the clinical information you can use. But one of the advantages of the EDW concept is that you can actually have hundreds to thousands of patients analyzed in your data set, unlike most clinical studies where you're limited to tens, maybe even a couple hundred patients. If you've ever wondered why we don't have a common EMR in the United States, this is probably a good reason why. Each circle here represents the clinical and billing professional subsystems at Vanderbilt University, and your institution probably looks very similar to this. So the inner circle represents all the subsystems that are incorporated into our enterprise data warehouse. And so basically what this means is that you have several different subsystems for billing, clinical data, and outcomes data that some talk to each other. Ideally, you'd like to get all of them to speak to each other, but practically speaking, that doesn't happen. The enterprise data warehouse is really used to kind of break down some of these barriers. So our informatics and in concert with our informatics, surgical, and finance teams, basically put these information systems into different bins. These go into the enterprise data warehouse, and being the clinicians involved in here, we were then able to advise on the final step to create the Vanderbilt Procedural Outcomes database. So basically, to create a disease-specific data set, it really involves four components. The first is administrative data. Second is clinical data from this EDW system, outcomes data, and then you can combine it with quality of life data as well. So to kind of get a handle on analyzing our patients, we divided patients to 8 clinically meaningful groups, and that included stroke, CNS tumor patients, patients with neuromuscular diseases, head and neck cancer patients, patients with other malignancies, trauma, cerebral palsy, gastroparesis, and other patients that included both medical and surgical issues. We followed patients for 30, 60, 90, 180 days, up to 1 year. This also represents an advantage of this type of approach where you can link this to Social Security Death Index data and get mortality information on all your patients. This included 2 years of PEGs done at Vanderbilt. So our results, we had 953 patients with a mean age of 57 years, 37% were women, mean ASA class just over 3, and these are the results and how our population broke down. The majority of patients were stroke, CNS tumor patients, pretty typical populations at your institution as well, head and neck cancer patients, trauma patients, and also we had a significant, not insignificant proportion in the other category of medical and surgical reasons to place PEGs. So major complications, we had 53 in this cohort, just under 6%. The majority of these were aspiration pneumonias or gastrointestinal bleedings. A significant proportion did require reoperation. 17% required therapeutic endoscopy. We had 12% of minor complications. Most of these were peritubular leaks, also combined with failure to do the initial procedure. These are most frequent in cerebral palsy and gastroparesis patients, and 29% required operation. These are mostly for surgical site or soft tissue infections. Looking at our overall mortality, ranged from 9% at 30 days to 30% at 1 year. These were all the disease processes. When you split these patients up by the disease processes, we see that a couple of things begin to fall out. The first is patients with other malignancies. These are patients who did not have head and neck cancers, nor did they have other neuromuscular or CNS tumor malignancies. These patients had the highest mortality curve overall. They started out just under 30%, and at 1 year it was close to 73%. Contrasting that with patients with other indications, they also had a very, very high mortality over the main group there. And patients with cerebral palsy and gastroparesis had the lowest overall mortality curve. So in conclusion, we define short and long-term mortality curves for clinically relevant disease categories. PEG placement for patients with non-CNS and non-head and neck malignancies should probably be abandoned or very carefully considered before placing the PEG. And finally, I think we've demonstrated that the enterprise data warehouse concept is a very, very useful tool where you can use many patients and come up with clinically meaningful conclusions. Thank you.
Dr. Freed, do you have a question? Don't run.
Ben, there's a great presentation and a very important and useful methodology. My only question really relates to your conclusion about whether or not the PEGs are actually indicated in these cases. I think one of the parts of your data that you didn't present are the quality of life data, and although patients may be dying a year out, it may have a great benefit for their quality of life and compared to the other alternatives available to them. Do you want to comment on the quality of life aspect?
Yeah, that's a great point, especially with the patients that have relatively short survival after PEGs. A great scenario for this is in the patient that has a bowel obstruction. Transitioning from a nasogastric tube to a PEG may offer some benefits. Certainly that's something worth looking at. Where that time frame falls into the quality of life discussion, it's difficult to say. There really hasn't been much data at all looking at this. We do know from literature in the cancer literature that adding a tube anywhere decreases people's quality of life, but certainly that scenario, which is not uncommon, may be the ideal scenario for a PEG.
Dimitri Olenek of Omaha, Nebraska. Dr. Poulose, I would also say that you should be thanked for casting some much-needed light on the actual morbidity of a PEG procedure. This is not a benign procedure, and it certainly has its cost. At our institution, the more complicated PEGs are referred to surgery, and we do this with usually a laparoscopic assist with a 5mm port. I'm curious whether you've looked at the cost consequences of some of these complications and whether that is going to drive your institution's decisions. Thank you.
Yeah, thanks, Dimitri. We haven't looked at cost yet. We know cost is borne out in complications, so I think that's certainly something worth looking at. We know that the complications do vary somewhat by disease process, but that's something we're investigating.
Thanks. Thank you.